All right. Well, good morning, everyone. We're going to be starting in just about 5 minutes. Thank you all so much for joining. Really appreciate it. I also wanted to let you all know that I'm going to be live streaming on YouTube. So feel free to share the link on your social or to your friends who may be also studying so we can all review together. I'm going to go ahead and put in the live stream link to share in the group chat. So hopefully you can see that in the chat, and I would encourage you to also open up your chat box as well and say hello where you're logging in from. We're going to get started in just a little bit. Really excited that you all are here, and thanks so much for joining. All right. Well, if you're just joining us, please go ahead and open up your chat box. Say hello where you're logging in from. Hopefully you all can hear me okay. Can I get a thumbs up if you can hear me okay, or a yes? All right. Excellent. Rockefeller's here. Sandeep Brandia, Irshad, Katya Bhavna. Excellent. Well, thank you all for joining in via Zoom. And if you're joining in on YouTube, really appreciate you all watching live. We're going to get started in just about a minute or so. Thanks so much for joining. All right, let's go ahead and get started. I am so excited to have you join me for the third block of this series called Tutor with Me. We have an international audience today, and I am super excited to spend this next hour and 15 minutes with you all. If you don't mind going ahead and opening up your chat box, saying hello, where you're logging in from, I'm going to get started with a little bit of an introduction. If this is your first session joining me, welcome. And if you've joined multiple sessions, I also welcome you back. My name is Rahul. I'm a pediatric critical care physician. I'm very passionate about medical education, particularly for high stakes exams like the USMLE. I have created a whole course and methodology of preparation based in active recall integrated learning. So I'm excited to share some pointers with you as we get started with our introduction. So what really makes HyGuru so unique? Well, HyGuru is, in my opinion, an evidence-based approach to USMLE preparation. I really focus on active recall, integration, and test-taking strategy. When we're talking about active recall, you're going to see it today. We're going to be going through questions to push your knowledge. Integration means that we are going to be taking concepts from one organ system and tying it in so that you can retain material. And test-taking strategy, understanding how to think like the test maker. Whenever I prepare students one-on-one or in my pass-fail course, I always focus on this triad. Number one, content integration and test-taking strategy, understanding why each sentence is in the vignette. I also focus on making sure that you are productive and you're going through the material in a systematic way. But one of the most important things that I'm very passionate about, and you can probably feel this in the energy as I'm talking to you today, is to optimize your test-taking psychology. Prometric exam day is stressful, and so my goal is to make sure you practice like you play during your dedicated study so that you can perform on exam day. I think most importantly, what has made HyGuru just an awesome journey so far is that HyGuru is an international community. Here are some pictures when HyGuru started. I used to teach live in the classroom, and I still do, but now COVID has also shifted the curve a little bit when it comes to learning. And now we have a global community of lifelong learners in medicine. And we have over 200 people joining us today, both on Zoom and YouTube. So just very humbled and grateful that you are here today, a part of this community. Here are some recent successes of the HyGuru family. I really have enjoyed seeing students progress in their journey, whether it's step one going into step two or step two and beyond. So I just wanted to share a few personal texts which I received that highlight some of the students' successes. Now, today, what we're going to be going through is a whole block of questions, and it's going to be similar to how I tutor one-on-one, so you get a flavor. But I also wanted to, at the end, share with you one of my most prized creations, and that is the USMLE Step 1 Pass-Fail course. Now, this course is based on adult learning theory and active recall learning. It is probably one of the most efficient ways to prepare for this exam, and it allows for you to really enhance your progress on NBME exams as I teach all of the organ systems and make sure that you understand the various vignettes behind the concepts that the USMLE likes to test. So feel free to check it out. I'm going to place the link right now in the chat box, and I will answer some more questions and give you some more information at the end. But without further ado, let's go ahead and get started with today's review. Are you guys ready to get started? Go ahead and type in yes into the chat box. All right. Nadine's ready. Stefan, Joe, Bedzada, Linton, Ravneet. Excellent. Well, thank you guys so much for joining. Make sure you have your chat box open so we can interact together. And I will also be answering questions at the end with the live Q&A. So what I'm going to be doing today is very unique. I'm going to start with the multiple choice question, give you a little bit of time to answer the multiple choice question. And what I'm going to do is I'm going to break down that multiple choice question, and it's an NBME style question. And we are then going to jump into content review. So we're going to take a question and then bam, go into the content review. And one of my favorite parts of this is that we are going to be going a step beyond. So yes, I'm going to tell you what kind of question you're looking at, what content specification the USMLE is testing you on, how to really capture the vignette, kind of like a flashcard. And then bam, we're going to take it one step beyond. And I'm going to give you an active recall question to make sure that you really understand the concept and the related concepts behind the question. I think when it comes to USMLE questions, UWorld questions, etc., it's important to recognize this framework. And that is that NBME and UWorld questions are going to start with the broad chief complaint. And it is your goal to kind of narrow down sentence by sentence in the history, which is the first part of the vignette, and the physical exam and labs, which are the second part of the vignette, to really isolate the pertinent positives and pertinent negatives so that you can get to a working mechanism or even a working diagnosis. And I'm actually very passionate about teaching this approach, and we're going to go through that step by step today. All right. So like I mentioned, please open up your chat box. Feel free to change the chat box feature to everyone rather than just host and panelists, and we can continue with our journey. All right. Let's go ahead and go with our first question today. So first start with the STEM. What action is most likely responsible for the anticipated beneficial effect of this medication? A 72-year-old woman presents with persistent hip pain for the past 2 weeks. She has been postmenopausal for approximately 15 years. On examination, she winces when moving her right hip, indicating localized discomfort. An X-ray of the pelvis shows a noticeable fracture in the right femoral neck region. She undergoes a DEXA scan, which shows a substantial decline in bone mineral density. Her lab results are going to show a normal serum calcium and phosphorus levels, and her serum alkaline phosphatase activity levels are also going to be within reference ranges. Her physician decides to start her on a bisphosphonate medication. What action is most likely responsible for the anticipated beneficial effect of this medication? A, increase or decrease in IGF-1, B, inhibition of osteoclast activity, C, reduction in osteoprotogerin production, D, increase in 125, vitamin D, E, promotion of osteoblast activity, or F, upregulation of NF-kappa B. What do you think is the best answer? Excellent. Well, bisphosphonates, if you are saying inhibition of osteoclast activity, you are absolutely correct. And remember, bisphosphonates have the dronate suffix that you need to know. The other thing that bisphosphonates cause are osteonecrosis of the jaw. So watch for a patient who has osteoporosis and then it has intense jaw pain. Bisphosphonates can also cause pill esophagitis, in which a patient is going to take a bisphosphonate and they are going to have subsequent dysphagia, and you're going to have eosinophilia potentially in your labs as well as endoscopy. One thing that I just want to really highlight is to recognize that osteoporosis has a normal lab values. It is going to be a decrease in trabecular bone matrix integrity, and you are going to have normal calcium, phos, and alk phos levels. And I just want to really highlight this because there are so many other pathologies in which you have up or down arrows. All right, excellent job. So this question was a pharmacology question related to bisphosphonates. Let's take it a step beyond. What is the monoclonal antibody which inhibits rank ligand and in turn inhibits osteoclast? Go ahead and put that into the chat. Monoclonal antibody which inhibits rank ligand and in turn inhibits osteoclast. Excellent. If you're saying denosumab, you are absolutely correct. Let's go ahead and just quickly review when it comes to osteoporosis, how to think about the cellular physiology. Here, you're going to have two cells. One is going to be an osteoblast, and the other is going to be a osteoclast. Remember that PTH is going to be binding the osteoblast. And when you're thinking about PTH binding the osteoblast is going to release rank ligand. Now, osteoprotogerin is actually going to intercept that rank ligand and actually is going to inhibit osteoclast from activating. But normally, rank ligand is going to bind to the rank receptor on the osteoclast, and thus you're going to get bone resorption. And remember, the USMLE wants you to know that osteoclasts are derived from the macrophage or monocyte lineage. Next question. What is the most appropriate interpretation regarding the impact of habitual physical activity on the risk for vertebral fractures? In an observational study focused on senior men, the calculated risk ratio for vertebral fractures among those who engage in regular physical activity is 1.4, the 95% confidence interval being 1.3 to 1.9. What is the most appropriate interpretation regarding the impact of habitual physical activity on the risk for vertebral fractures? Statistically insignificant, statistically insignificant, statistically significant, or statistically significant? Go ahead and read through the answer choices and tell me what you think. Excellent. Well, the calculated risk ratio is going to be greater than 1. So it is not going to cross 1 in terms of the confidence interval. So A and B are going to be out. And when you're thinking about the risk ratio, remember, it's important to understand that the exposure in this case was in the numerator, and that's why you have a statistically significant increase in overall risk. So this was a biostats or experimental type question. What you want to note is that whenever the relative risk or even odds ratio is going to cross 1 in the confidence interval. So as you can see, the calculated value is 1.4, but the confidence interval is 0.9 to 1.8. So it crosses 1. The conclusion that you can garner whenever it crosses 1 is going to be that the intervention and the control is not going to be statistically significant. All right, let's go ahead and go through this question. What is the mechanism of action of the most suitable immediate treatment for this patient? So a 48-year-old man arrives to the emergency room after experiencing sudden chest pain that spread to his left arm while he was mowing the lawn. His heart rate is at 85 and blood pressure reads 120/80. His lung sounds are clear upon auscultation, and the cardiac exam reveals an S4 gallon. As his EKG is being performed, he reports the recurrence of his chest pain. What is the mechanism of action of the most suitable immediate treatment for this patient? Go ahead and put your answer into the chat box. A, augments cyclic AMP. B, enhances nitric oxide concentration. C, suppresses potassium channels. Or D, inhibits sodium channels. Excellent. If you are thinking that this patient is going to have acute coronary syndrome, potentially unstable angina, you're absolutely correct. Remember that this patient is going to have exertional chest pain. And whenever you have exertional chest pain, I think of it as a supply-demand imbalance. Remember that there could be a coronary artery plaque, and the myocardial oxygen demand is actually going to be very high. And as a result, you're going to get a visceral pain that then is going to translate into a somatic pain. Remember that the patient is going to have an S4, so that indicates that he may have hypertrophy of his left ventricle. And remember that as his EKG is being performed, he has a recurrence of the chest pain. So that indicates that he may have unstable angina because it is occurring at rest. Recall that when it comes to nitroglycerin, it is going to act via cyclic GMP, not cyclic AMP, and it is going to enhance nitric oxide concentration. Very good. So this was a cardiac pharm question testing you on nitroglycerin. Let's go ahead and take it a step beyond. What medication could decrease the reflex tachycardia associated with nitroglycerin? What do you think is the best answer here? Medication that could decrease the reflex tachycardia? If you're saying beta blocker, you are absolutely correct. Remember that nitroglycerin is going to cause you to have vasodilation. Preferentially, it's venodilation, but there is arteriolar dilation as well. That stimulates the carotid baroreceptor reflex. Whenever you have vasodilation, subsequent carotid baroreceptor reflex activation, you end up getting reflex tachycardia. Remember that beta blockers, specifically beta 1 blockers in particular, are going to be used to blunt the reflex tachycardia effect. And remember, beta blockers in combination with nitrates are going to reduce the myocardial oxygen demand. And as a result, they are going to be very effective when it comes to angina. All right. Which of the following most likely contributed to the formation of this tissue due to its increased activity? A 28-year-old woman presents for a follow-up examination. She has received emergency treatment 2 weeks prior after accidentally pouring boiling water over her right arm while working in a coffee shop. Examination of the right forearm reveals a reddish, swollen 6-centimeter wound with a granular and soft appearance. Which of the following most likely contributed to the formation of this tissue due to its increased activity? A, C3b, B, glycosylation-dependent cell adhesion molecule 1, C, P-selectin, D, stromolysin, or E, VEGF? What do you think is the best answer? Excellent. And everybody is staying active and engaged. Remember that this question is basically testing you a little bit on the changes that you are going to get after a burn or wound healing, essentially. And remember that granulation tissue is going to have blood vessels, fibroblasts, and myofibroblasts. Remember that these are what's going to give you the type 1 collagen scar formation eventually, and the contraction of the wound. And the blood vessels are going to promote more nutrients to get to that area for wound healing. And the erythema is going to be due to the neovascularization thanks to VEGF, which is going to be the best answer here. So this is going to be a derm question on wound healing. Let's go ahead and take it one step beyond. What is the primary second messenger receptor utilized by growth factors? What do you think is the second messenger system that growth factors use? Go ahead and type that into the chat. Excellent. So remember that when you're thinking about growth factors, it's going to be a tyrosine kinase MAP pathway receptor. We're going to be talking about the difference between the JAK-STAT and the MAP pathway a little bit later on. But recall that when it comes to endocrine hormones or any sort of protein-based hormones, you are going to have the binding at the cellular surface. That is completely different than the mechanism of steroid-based hormones. What are your steroid-based hormones? Steroid-based hormones are things like aldosterone, cortisol, DHEA, or specifically testosterone, actually. Okay. All of these are going to be your adrenal cortex hormones. And in the case of aldosterone and cortisol, and then the testosterone that comes from your gonads, those are going to be not cell membrane receptors. They are going to be intracellular or intranuclear binding domains. And the USMLE loves for you to know that because it tests the general principle that steroid hormones are lipophilic. They cross lipid bilayers. That's even true when you're talking about anesthetics. the more lipophilic the anesthetic is, the more it's going to cross the blood-brain barrier, and you're going to have a good amount of potency with that anesthetic. Excellent job, everyone. Let's go ahead and go into our next question. But before I go into our next question, I'm just going to do a check-in. Is everybody learning something? Go ahead and type in yes into the chat box or thumbs up. All right. Irshad, Alejandra, Rockefeller, Linton, Ahmed, Carla. Okay, everybody's learning. That's excellent. Let's go ahead and keep going in our review. The advantageous effect of this medication can most likely be attributed to the overactivation of which of the following. A 32-year-old man comes to the hospital half an hour following a serious bicycle accident. He is found to be minimally responsive to stimuli on physical exam, while the remainder of his neurological exam doesn't reveal any abnormalities. An X-ray of his skull reveals a non-displaced fracture at the base of the skull. 2 weeks into the hospital stay, he begins to experience excessive thirst and urination. Lab tests indicate normal serum glucose, elevated serum osmolarity, and lowered urine osmolality. After desmopressin is administered, a rise in urine osmolality is observed. The advantageous effect of this medication can most likely be attributed to the activation of which of the following? A, adenyl cyclase, B, calcium channels, C, Janus kinase, D, serine kinase, or E, tyrosine kinase. What do you think is the best answer? Excellent. If you are saying A, adenyl cyclase, you are absolutely correct. Let's go ahead and integrate this question a little bit more. Remember that when you see polyuria, polydipsia, and polyphagia, you want to tell yourself that they're testing diabetes. Now, obviously, if it is going to be a glucose problem, that is going to be diabetes mellitus. However, in this case, the glucose was normal, so you're going down the insipidus route. And remember that in diabetes insipidus, you either have a deficiency of ADH or ADH is there and it is not working, i.e. nephrogenic diabetes insipidus. So when it comes to a brain trauma, typically you are going to see central diabetes insipidus. Now, if this is going to be the collecting duct and this is going to be the peritubular capillary, in central diabetes insipidus, you do not have any aquaporins, so you're not going to reabsorb water. As a result, your serum osmolarity is going to go up, as well as in your labs, you're going to see hypernatremia in the question. Because all of that free water is in the P, your urine osmolarity or your spec grav in your question is going to be very low. So remember that when you're giving DDAVP, it is going to be a ADH analog. And ADH analogs work via increasing V2 receptor activity. And remember, V2 acts via the GS pathway, which is adenylate cyclase and cyclic AMP. The V2 receptor is upregulated. You're going to have aquaporins that are going to be inserted into the luminal membrane, and you're going to bring free water in and thus have a rise in your urine osmolarity, as you can see in this question. So best answer, adenyl cyclase, and we're talking about DDAVP hitting the V2 receptor. So this was an endocrine farm question, and let's go ahead and take it a step beyond. What medication acts as a V2 receptor antagonist? What do you think is the best answer here? Excellent. If you are saying the Vaptan drugs, you are absolutely correct. When do we use Vaptans? We use Vaptans in SIADH when the patient is going to be refractory to fluid restriction, for example. And remember that Vaptans are going to act opposite from DDAVP. DDAVP, V2 agonist, whereas Vaptans, V2 antagonist. So they would decrease cyclic AMP. Let's go ahead and go into our next question. The pathogen caused this child's illness is most likely characterized by which of the following? An 8-month-old boy is brought to the doctor's office with a 3-day history of fever and a cough. His symptoms began with a mild fever and an abundant transparent nasal discharge. His cough became wet and non-productive a day ago, and his breathing has become very fast. He is up to date on all of his recommended vaccinations. He goes to a busy nursery and has 2 older siblings in elementary school. His vitals are notable for fever and mild tachypnea. His chest examination displays respiratory distress with intercostal indrawing, and auscultation reveals widespread wheezing and expiratory rhonchi bilaterally. The pathogen causing this child's illness is most likely characterized by which of the following? A DNA genome, B, double-stranded nucleic acid genome, C, absence of viral polymerase in the mature virion, D, entry into cells facilitated by a fusion protein, or E, ability to survive on surfaces for several weeks. What do you think is the best answer? Go ahead and type that into the chat. All right. If you are thinking that this child has RSV, you are absolutely correct. So let's go through this. Whenever you are going to see the first sentence in a vignette, you always want to make sure that you understand the tempo of the disease. So in this case, it is going to be less than 2 weeks, i.e. it's acute. Whenever you're thinking acute, you should be thinking about infection, trauma, inflammation, allergic reactions, okay? All of these are going to have a quick onset. So obviously with the fever and a cough, you're going to be thinking more of the infectious route. Now, this is telling you that the patient has respiratory symptoms, particularly upper respiratory symptoms. So transparent nasal discharge means that the patient has rhinorrhea. And then the wet, non-productive cough may tell you that the patient has either a pharyngitis, this is part of his viral syndrome, or maybe even a pneumonia. But what rules out a pneumonia in this situation, specifically a bacterial pneumonia, is the fact that the patient has widespread wheezing and expiratory rhonchi bilaterally. Typically, a bacterial pneumonia is going to have unilateral crackles. And so this tells you that this is a viral infection causing you to have lower respiratory disease. And whenever you think about wheezing, you should be thinking about bronchiolar or bronchiole narrowing. And this is going to be a sound heard primarily on exhalation. This sentence right here tells you that it could be viral in the setting of sick contacts. Another thing that the USMLE likes for you to note is that RSV typically happens in the winter months. So watch for that in the HPI. Remember that RSV is going to have the fusion protein, which is going to act via fusion protein or the F protein, and that is going to cause the syncytia of the cells, or the cells are going to come together. Very important for you to note. So when it comes to RSV, the treatment usually is going to be supportive. We're going to give children oxygen, make sure that they stay well hydrated. And we, in high-risk populations, are going to give a monoclonal antibody to prophylax or prevent severe RSV infection. So what medication inhibits the F protein of RSV? That's your step beyond question. And that is going to actually be palivizumab. Palivizumab is going to be indicated in babies who are going to be premature, who are going to have congenital heart disease, high-risk populations that would otherwise get severe RSV infections. We give this in the winter months to them. All right, let's go ahead and keep going on our journey. Which of the following types of drugs is the most appropriate pharmacotherapy for this patient? A 16-year-old boy is rushed to the emergency department approximately 20 minutes after being stung by a wasp. He has GI cramping and no difficulty swallowing. Vitals are notable for tachycardia and tachypnea. Physical exam shows no urticaria. Bilateral wheezing is heard on auscultation of the chest. Which of the following types of drugs is the most appropriate pharmacotherapy for this patient? A, alpha-1 agonist, B, muscarinic antagonist, C, alpha-1 adrenergic antagonist, D, beta-2 adrenergic agonist, or E, beta-2 adrenergic antagonist. What do you think is the best answer here? Excellent. If you are saying D, beta-2 adrenergic agonist, you're absolutely correct. So in this case, again, it is an acute tempo. And what you want to always note in USMLE questions is the trigger. In this case, the trigger is a wasp, and then the patient had multi-system involvement, GI cramping, as well as tachypnea and wheezing. This multi-system involvement is most likely due to allergic reaction, and in particular, anaphylaxis, which is going to be a lot of histamine that is going to be throughout the body. Now, what this histamine does is it's going to cause you to have bronchoconstriction. It's going to cause you to have vasodilation as well. So you are going to use epinephrine. And remember, IM epi is going to have beta-1 is equal to beta-2 effects. And at some higher doses, it can have alpha-1 effects as well. But the best answer is going to be beta-2 adrenergic agonist, okay? So what is high yield for us to know is that when it comes to anaphylaxis, we need to use sympathomimetics, specifically epinephrine. Epinephrine is going to have beta-1, beta-2, and it may also have some alpha-1 agonistic activity, but the primary effect is going to be beta-mediated. Now, what hypersensitivity is related to anaphylactic shock? That is going to be type 1. And remember that that is going to be related to IgE cross-linking on pre-sensitized mast cells. Typically, you are going to need 2 exposures prior to getting sensitized and subsequently becoming allergic. Remember that when you're talking about an immunology integration, the cytokine responsible for class switching from IgM to IgE is going to be IL-4, and that's high yield for you to know. All right, let's go ahead and go through this question. What is the most likely diagnosis for this patient's condition? A 16-year-old boy is brought to the doctor's office because of a 3-day history of a sore throat and fever that tends to spike in the evenings. For the past week, he's been feeling increasingly tired. He recently became sexually active, engaging in unprotected sex with a single partner. His appearance is that of a sick person. His temperature is elevated. On physical exam, cervical lymph nodes are enlarged, and the throat is red, covered with a white exudate. What is the most likely diagnosis for this patient's condition? A, candidiasis, B, herpangina, C, infectious mononucleosis, D, mumps, or E, syphilis. What do you think is the best answer here? Excellent. If you are saying that the patient is going to have infectious mononucleosis, you're absolutely correct. Let's go ahead and go through a breakdown. Remember that this patient is going to have sore throat and fever. So whenever you're thinking about fever, you're going to be thinking about itis. Itis could be infectious or inflammatory, but sore throat plus an itis, that's known as pharyngitis. And what's important for us to know is that the history of present illness, which is going to be up here, that HPI and chief complaint is usually intimately related to the physical exam. In the physical exam, we recognize that this is an exudative pharyngitis. And in a patient who is going to have fatigue and exudative pharyngitis, who's going to be a teenager with cervical lymphadenopathy, you're going to be thinking of infectious mononucleosis due to a DNA virus, which is going to be EBV. Let's go ahead and go through the step beyond question. What anticipatory guidance would you provide a patient with mononucleosis? What do you think is the best answer? Let's say that he was a football player, for example. Excellent. remember that these patients can end up having splenomegaly. And if the spleen is injured, the patient can actually end up succumbing to hemorrhagic shock. So the anticipatory guidance is going to be avoid contact sports until resolution. All right, let's go to our next question. Given this observation, the relentless tumor growth despite radiation therapy is most likely due to an impairment in cell cycle arrest during which of the following cell cycle phases? A 59-year-old man undergoes radiation for squamous cell lung carcinoma. Despite the treatment, the tumor continues to grow, leading to his demise 7 months later. The cells from his tumor exhibit a point mutation in p53, resulting in an ineffective gene product. Given this observation, the relentless tumor growth despite radiation therapy is most likely due to an impairment in cell cycle arrest during which of the following cell cycle stages? A, G0, B, G1, C, G2, D, M, or E, S. What do you think is the best answer here? Excellent. Remember that this patient is going to have a loss of p53. Now, just giving you a little bit of a background as to how I think about neoplasia. Neoplasia is going to be either the cell cycle proliferating too much or a lack of apoptosis. If you are going to have no p53, remember that you are then going to have an unregulated progression from G1 into S phase. And p53 normally is going to be a off-on switch between this area. And so when it comes to the best answer to this question, it is going to be G1. What's high yield for us to note is that there are two major mediators that are going to allow for cell cycle progression. Number one is going to be p53. Remember that p53 mutations cause you to have more cell cycle. Number two, it's going to be retinoblastoma and its effect on elongation factor 2. Remember that retinoblastoma, I think of it as a bouncer, i.e., it's going to protect elongation factor 2. However, when retinoblastoma is inactivated, elongation factor 2 is going to cause unregulated progression into the cell cycle. So, chapter 3 of pathoma, neoplasia. Whenever you see a neoplasia, you should think of increased cell division or decreased apoptosis. Very high yield for you to know. So this was a pathophysiology based question, and let's go ahead and go a step beyond. A patient with squamous cell carcinoma of the lung presents with hypercalcemia. What is the likely mechanism? Go ahead and put your answer into the chat box. Very nice. You got it. It is going to be increase in PTHRP. Remember that that acts just like parathyroid hormone. So you're going to have hypercalcemia as osteoclasts are going to be activated. You're going to have low phos, and you are going to have an elevation in 125 vitamin D. All right, here's a question that has labs in it. Let's go ahead and STEM paraphrase and predict. What is the most plausible explanation for the biopsy results? A 28-year-old man visits the doctor due to a year-long history of painful urination, which has worsened over the past month. He also has incidents of bloody urine for the past 5 years. Originally from sub-Saharan Africa, he moved to the US 6 months ago to attend graduate school. His vital signs include a temp of 38, pulse of 80, respirations normal at 16, and blood pressure 110/84. Examination reveals suprapubic tenderness, and lab results are as follows. He has a leukocytosis with a slight increase in eosinophils. His BUN and creatinine are elevated, and his UA shows 3+ blood with no RBC casts. Imaging reveals bilateral hydroureter, hydronephrosis, and calcified areas near the bladder. Bladder biopsy shows severe chronic inflammation, fibrosis, and sporadic granulomas. What is the most plausible explanation for the biopsy results? A, exposure to a chemical toxin, B, interstitial cystitis, C, schistosomiasis, or D, vesicoureteral reflux? What do you think is the best answer? Excellent. So this patient is going to have a chronic tempo to his disease. This patient is also going to have risk factors such as being an immigrant. The patient is going to have longstanding hematuria. And especially in the setting of being an immigrant, he may have actually picked up a parasite, schistosomiasis, and that's why for parasitic infections, it's important to look at the differential when you're thinking about parasites because they can have eosinophilia. What's also important for us to note is that whenever you're worried about cystitis of the bladder, you're going to get suprapubic tenderness. And this goes back to understanding that abdominal physical exam on the USMLE is usually quadrant focused. So suprapubic tenderness indicates that it's bladder or even maybe some of the reproductive areas. Now, what I want you to do is whenever you look at the labs, you always want to figure out what organ is going to be messed up. So whenever you see BUN to creatinine, you are going to say that the kidney is going to be messed up. And what's high yield for us to note is that you want to do the BUN to creatinine ratio. In this case, the patient may actually have post-renal AKI. And post-renal AKI, you can end up having a BUN to creatinine ratio of greater than 20:1, which then over time can progress to 10 to 15:1 in terms of your BUN to creatinine ratio, indicating that the post-renal damage now is such a severe stress that you're actually having intrinsic kidney injury. What's also important to note is this pertinent negative right here. And this pertinent negative, no RBC CAS, tells you that it's not a nephritic syndrome causing your disease, i.e. it's not glomerular in etiology. So think more macroscopic anatomy, think more ureter, bladder, etc. So the best answer here is going to be schistosomiasis. Let's go ahead and go into the step beyond question. What end organ dysfunction would be associated with not Schistosoma hematabium, but Schistosoma mansoni? What do you think is the best answer here? So Schistosoma mansoni actually is going to be related to periportal fibrosis. And so these patients can have portal hypertension and ascites. And that's really important distinction. Hematabium is more bladder cancer, mansoni, portal hypertension, and there's Schistosoma japonicum, which is going to be related to intestinal bleeding. So when it comes to schistosoma and how you are going to integrate it for your microscopy questions, remember that the terminal spine is going to be your schistosoma hematabium, whereas your lateral spine, that's going to be primarily your schistosoma mansoni. All right, let's go ahead and go through this question. If these deletions are in trans, what is the likelihood that their offspring will have a 2-gene deletion? A couple considering parenthood seeks genetic counseling as they both have a history of alpha thalassemia in their families. The woman has a slightly decreased hemoglobin concentration, and genetic studies reveal a single gene deletion. The man has a microcytic anemia and a 2-gene deletion. If these deletions are in trans, i.e. one deletion on the paternal and maternal genes, what is the likelihood that their offspring is going to have a 2-gene deletion? Go ahead and put your answer into the chat box. 0, 25%, 50%, 75%, or 50%. All right. So this question is pretty interesting. Basically, what you need to focus on is when it comes to trans, that means in alpha thalassemia that you are going to look at moms as well as dads. So mom actually is going to be, for example, little a, which this one is the abnormal, and dad is going to be AA. So dad's probability is going to be 1 to give the gene, whereas mom has 1 normal one. So there's a 50% likelihood. So the best answer here is going to be 50%. Now, what's also high yield for us to note here is that the mom is going to have only 1 deletion, which is relatively asymptomatic. It's like alpha thalassemia minima, whereas you can have alpha thalassemia minor when you are going to have 2 genes deleted. Remember, 4 genes encode for your alpha thalassemia or alpha gene when it comes to hemoglobin. All right. On to our next question. Based on the patient's clinical presentation and lab findings, which of the following diagnoses is most likely? A previously well 35-year-old school librarian presents to the urgent care clinic with a 48-hour history of high-grade fever, generalized fatigue, and intermittent episodes of disorientation. She also mentions recent onset of difficulty in reading small print. She has no significant past medical history, and she's not on any regular medications. She is a non-smoker and drinks socially. On examination, her temperature is febrile, pulse is fine, respirators are fine, and blood pressure is a little bit hypertensive. Examination of her skin reveals widespread petechiae and bruising, particularly on her arms and legs. Neurological exam reveals slight disorientation to time and mild generalized weakness, but no focal deficits. Her lab studies are significant for anemia, normal white blood cells, thrombocytopenia, normal PT and PTT, high BUN, and high LDH. A peripheral blood smear demonstrates increased polychromasia and abundant schistocytes. Blood culture from both blood and urine are negative for any microorganisms. Her chest radiograph shows no abnormalities. Based on the clinical presentation and lab findings, which of the following is most likely? A, CLL, B, autoimmune hemolytic anemia, C, a platelet depleting microangiopathic disease, D, septic shock, E, bleeding disorder related to von Willebrand factor deficiency. What do you think is the best answer here? All right. Lot going on in this question. So let's break this question down. This patient comes in with fever plus disorientation. So in this situation, you're worried potentially of an infectious cause like encephalitis, or because there are 2 or more organ systems involved, you may think that this is a multi-system process. And you're absolutely correct, because as the vignette is going to build, you notice that the patient has quantitative evidence of a fever, but then has signs of thrombocytopenia. The patient has CNS abnormalities as indicated by the disorientation. And then the patient is going to have anemia, which is microangiopathic because the patient on the smear has schistocytes. Thrombocytopenia, which is again going to relate to the petechiae that you see on the physical exam, and evidence of acute renal failure, specifically the elevated BUN. The LDH just indicates that you're going to have a microangiopathic hemolytic anemia. So this is going to be the pentad of TTP. And this is super important for us to note that TTP is going to be a platelet depleting microangiopathic disease. Let's go ahead and just integrate this. This was one of my OG slides when I started HyGuru. This was one of the first slides I made. Essentially, what I want to do is I want you to appreciate that HUS and TTP are on a spectrum, okay? So let's talk about HUS. Typically, HUS is going to be due to E. coli 015787, and that has the Shiga-like toxin that inhibits translation, i.e., it inactivates the 6DS ribosomal subunit. Now, all of this causes increased amount of cytokine release. And what that's going to do is that's going to cause you to damage vascular endothelium. Endothelial injury is part of a nice integration with Pathoma chapters 1 through 3 when you're thinking about Virchow's triad. You are going to get microthrombi that are going to deposit in between endothelial cells of the blood vessel, so right here. And what that's going to do is any platelet that goes over that speed bump is going to be consumed, and that's why you have thrombocytopenia. Now, these speed bumps are going to grow to the point where you're going to have intravascular mechanical shearing of red blood cells. Any red blood cells go by, turn into a helmet cell after all. And this is where you get the schistocytes, anemia, and remember in our question, the patient had elevated LDH. If this happens in the renal vasculature, that can decrease renal blood flow, and you can get acute renal failure. But remember that HUS is a triad of hemolytic anemia, thrombocytopenia, and acute renal failure. And if you add fever and altered mental status, which is what we had in our patient, you have progressed to TTP. Now, typically TTP is going to be a deficiency, either acquired or genetically induced deficiency of an important matrix metalloprotease. And that is actually going to be our next step beyond question. Which genetic mutation can lead to the development of TTP, thrombotic, thrombocytopenic purpura? And best answer is Adams TS13. Remember, Adams TS13, very high yield for NBME questions, that it is a matrix metalloprotease. What it does is it is going to take von Willebrand factor and it is going to chop von Willebrand factor into smaller pieces. And a matrix metalloprotease, I like to think of it as a machete in the jungle. It takes a big thing and chops it up into small pieces. If you are going to have no Adams TS13, this big von Willebrand's multimer is going to deposit in between endothelial cells. And with the inflammation, you are going to have increased microthrombi and thus a platelet-consuming disease and a microangiopathic hemolytic anemia. All right, everyone. Excellent work so far. Is everybody doing okay? Yes, no, maybe so? All right, Ahmad is. Excellent. And I love the discussion in the chat box. Thank you all so much. For time purposes, I'm not going to perseverate too much in the chat box, but I appreciate everybody's energy and focus. We have over now 200 people joining us, so this is great. Let's go ahead and keep going in our quick little rapid review. All right. So what is the most likely diagnosis? A 22-year-old rock climber falls onto a sharp rock protrusion, sustaining injury to his right side. He is brought to the emergency department complaining of pain and difficulty breathing. A chest x-ray reveals the presence of fluid and air in the right side of the chest cavity, minor collapse of the right lung, and a slight shift of the stomach bubble. There is no shift in the mediastinum, excuse me. What is the most likely diagnosis? Non-tension hemopneumothorax, non-tension hemothorax, non-tension pneumothorax, tension hemopneumothorax, tension hemothorax, or tension pneumothorax. What do you think is the best answer here? Excellent. So this patient is going to have acute chest trauma. And when you're thinking about acute chest trauma, you should be worried about 3 areas: the ribs, the heart, causing, for example, a cardiac contusion, or some sort of lung pathology. In this case, they really focus on the lungs. And the patient has minor collapse of the right lung, so there is going to be a small pneumothorax. There is no shift of the mediastinum, so tension can be ruled out. And this was kind of like an arrow question, but recall that whenever you have a tension pneumothorax, you're going to have the mediastinum that is going to be shifted contralateral to the side of the lesion. Now, in this case, the patient is going to have air fluid levels indicating the potential for blood in the chest cavity in the setting of trauma. So the best answer is going to be a non-tension hemopneumothorax. Let's go ahead and take a look at this. Remember that when you're thinking about an X-ray, it is going to be facing the patient. So this is going to be the left side of the patient. This is going to be the right side of the patient. And as you can see, there is some air fluid levels and a complete opacification of the right lung. Now, what's high yield for us to know is that the costophrenic angle is going to be blunted. In the setting of trauma, you are going to be thinking of blood blunting the costophrenic angle. But in the setting of, let's say, infection or inflammation, let's say you have a lupus patient, that could actually be exudative fluid. So just something for you to note is that whenever you think of a blunting of the costophrenic angle on a chest X-ray, think about fluid or blood being in that area. All right, let's go ahead and go into our next question. Which of the following changes in her serum lipid profile is most likely to be seen in the follow-up visit? A 52-year-old woman visits the healthcare center for a routine checkup. Her family has a significant history of heart disease. Over the past few visits spanning a couple months, her blood pressure readings have fluctuated between 155/90 and 135/80. On this visit, her blood pressure is measured at 145/85. Other than her blood pressure, the physical exam reveals nothing abnormal. Laboratory tests reveal elevated total cholesterol, normal HDL, and elevated LDL and triglycerides. The healthcare provider decides to start her on rosuvastatin and candesartan. Which of the following changes in her serum lipid profile is most likely to be seen in the follow-up visit? Let's go ahead and go through this arrow question. I'll give you some time to put your answer into the chat box. Excellent. So this patient has started on a HMG-CoA reductase inhibitor. And remember that reduces cholesterol. It has the most profound effect on reducing LDL. However, the statin is actually going to give you slightly increased HDL, and it is going to decrease your triglycerides, not as good as fibrates. What is going to be candesartan? Well, if it's sartan, that's going to be a angiotensin II receptor blocker, and that's high yield for you to know. Now, a couple things that I want to integrate here. In biochemistry, there's HMG-CoA reductase, which inhibits cholesterol, but also there's something called HMG-CoA synthase. Now, HMG-CoA synthase is the rate-limiting enzyme for ketone body synthesis. So I just want you to keep those straight. When it comes to ACEs and ARBs, please note that ACE and ARB is going to be the right answer for anybody who has diabetes with either micro or macroalbuminuria and diabetes and hypertension. The USMLE just loves for you to know that when it comes to diabetes and hypertension, we use ACEs and ARBs. And remember that ACE inhibitors can actually increase the amount of bradykinin. And when you increase the amount of bradykinin, you can actually get a nagging cough. Now, if the patient is going to have ACE inhibitor-induced cough, you are going to pivot and you're going to use ARBs, for example, such as a sartan. All right, let's go ahead and go through the integration here. Remember that when it comes to statin therapy primarily is going to cause you to have hepatotoxicity at times or myopathy, especially when combined with fibrates and niacin. What vitamin is this patient most likely lacking? A 70-year-old man visits the doctor with complaints of a constant sense of fatigue and numbness in his hands and feet for the past 6 weeks. Upon examination, the doctor notes weakened movements in both upper and lower limbs, more so in the lower limbs. Hyperactive deep tendon reflexes are observed in the knees and ankles. Sensory tests reveal a loss in the ability to discern vibration and spatial awareness in all 4 limbs, more so in the legs than in the arms. What vitamin is this patient most likely lacking? A, pantothenic, thiamine, riboflavin, D, pyridoxine, or E, cobalamin? What do you think is the best answer here? Excellent. Let's go ahead and go through this. In this question, the patient is going to have a subacute to chronic neuropathy. And whenever you're thinking about neuropathy, you want to be thinking about the nerve either denervating or there is something hitting the myelin. And so you're having less myelin, either saltatory conduction or actual myelin surrounding the nerve. What this patient is also going to have is abnormalities in the deep tendon reflexes. Specifically, the patient has upper motor neuron signs. And this patient most likely has damage to the corticospinal tract because of these upper motor neuron signs. Also, the patient is going to have decreased proprioception and vibration. So along with the neuropathy and proprioception and vibration, you're isolating the lesion to the dorsal column medial lemniscus system. So this is going to be subacute combined degeneration of the cord. And so the best answer is going to be E, vitamin B12 or cobalamin. Recall from a biochemistry standpoint that vitamin B12 is going to be an important cofactor for the enzyme methyl malonyl CoA mutase. And what that does is it takes products from odd chain fatty acids, and it is going to take these byproducts from odd chain fatty acids like propionyl CoA and integrate it into energy via telling it to enter into the TCA cycle as succinyl CoA. And so what's high yield for us to note is that if you're not going to have any B12, you won't be able to get propionyl CoA into succinyl CoA, and you won't have as much energy. But most importantly, you will build up a toxic mediator, and that is methylmalonic acid. And methylmalonic acid is going to be toxic to your nerves, and that's why you had the neuropathy in the question. Recall that B12 deficiency is going to be a cause of high MCV anemia. So watch for low hemoglobin and high MCV in your exam question. And remember that on peripheral smear, you're going to have hypersegmented neutrophils. And that's very high yield for you to note. So what pathology would have DCML and not corticospinal tract, but DCML and dorsal root ganglion? Go ahead and type that into the chat as your step beyond question. What pathology would have DCML pathology and dorsal root ganglion? Excellent. If you're thinking about Tabes dorsalis or tertiary syphilis, you are absolutely correct. Very good. All right. Next question. What is the most likely triggering the acne in this patient? A 16-year-old girl visits the doctor's office troubled by persistent acne for the past few months. She hit puberty at the age of 13, with the onset of menstruation occurring when she was 15. Physical assessment reveals a spread of both open and closed comedones over her chin and nose. Her breast and pubic hair correspond to Tanner stage 5. What is the most likely trigger for the acne in this patient? So A, diminished parasympathetic response, B, elevated levels of estrogen, C, heightened sensitivity of the sebaceous glands to FSH, D, increased sympathetic activity, or E, activation of the sebaceous glands by androgens. What do you think is the best answer here? All right. So this female is going to have relatively normal development, and this is going to, the acne specifically, is going to be due to increased amounts of androgens causing the activation of sebaceous glands. Sometimes you can get those sebaceous glands plugged up. You can get keratinization. You can also get co-infection with P. acnes that can actually cause you to have inflammatory acne. So let's go ahead and go into the step beyond question. What disorder presents with premature puberty, cafe au lait spots, and fibrous bone dysplasia? The triad of precocious puberty, cafe au lait spots, fibrous bone dysplasia? If you said McCune-Albright syndrome, you're absolutely correct. Whenever you think of cafe au lait spots, typically you want to knee jerk to neurofibromatosis. But whenever you see premature puberty and fibrous dysplasia of the bone, you're going to be thinking about McCune-Albright syndrome. And this is an example of mosaicism. Remember, if you have a germline mutation in the genes that can cause McCune-Albright syndrome, that could be fatal. However, mosaics are going to end up surviving and presenting with the triad. All right, moving on. Based on these findings, which of the following processes is most likely occurring in the region with decreased staining? A 5-year-old boy from South Africa is brought to the pediatrician by his parents due to a week-long history of painless swelling of his left cheek and pressure around his eyes. He is tall and well-nourished for his age, ranking at the 85th percentile for both height and weight. Upon physical exam, a solitary 13 by 11 centimeter lesion is observed on the left side of his cheek, which is non-well-defined and has irregular boundaries. A biopsy of the lesion was taken under the microscope, and it exhibits hypostaining areas with scattered macrophages amidst a sea of medium-sized lymphocytes. Based on these findings, which of the following processes is most likely occurring in the region with decreased staining? A, programmed cell death. B, uncontrolled cell death due to injury. C, cell death due to lack of oxygen. D, bone formation. Or E, fusion of 2 or more cells. What do you think is the best answer here? So this patient is going to have a rapidly progressive jaw mass. The patient is of African descent. So you should be thinking about Burkitt's lymphoma. And remember that Burkitt's lymphoma is going to have the starry sky appearance with tingeable body macrophages. That indicates that there is increased cellular proliferation, and there is also going to be increased amounts of macrophages that are going to cause you to have areas of hypostaining, which is related to A, programmed cell death or apoptosis. Remember that when you are thinking about a malignant tumor, it is going to have irregular boundaries. So watch for that as a test taking tip in your USMLE questions. Here is going to be Burkitt's lymphoma. Again, starry sky appearance with these areas of apoptosis thanks to the tingeable body macrophages. I do want to integrate a little bit of chapters 1 through 3 of pathoma. General principles I find is very high yield for your USMLE. Remember that there is a difference between necrosis and apoptosis. Necrosis, you can think of big picture, it's messy. Apoptosis, it's going to be clean. Necrosis involves cellular swelling and then changes in your nucleus. It involves subsequent inflammation, and the plasma membrane is disrupted. And usually this is pathologic. Typically, it's going to be due to a lack of oxygen delivery. Apoptosis is going to be both physiologic and pathologic. And as you can see in the prior picture related to Burkitt's lymphoma, the plasma membrane is intact. There's no subsequent inflammation, and apoptosis is the falling of the leaves. You're just going to have things, cells that are going to shrink. Let's go ahead and go into our step beyond question. What is the chromosomal translocation for Burkitt's lymphoma? Go ahead and type that into the chat. Absolutely. If you're saying 814, you are absolutely correct. Recall that chromosome 14 is going to code for immunoglobulin, which is usually constitutively active. It's going to keep proliferating to go immunoglobulin, immunoglobulin, immunoglobulin. If you are going to have c-MYC that is now going to be on that chromosome 14, and now you have this translocation, you are going to have increased cell cycle division, and you are going to end up getting this Burkitt's lymphoma. All right, here's our next question. For a thorough investigation of potential metastasis in this patient, it would be most suitable to examine which of the following lymph nodes first. A 56-year-old man presents to the clinic due to a half-year history of an abnormal growth on his tongue, which has been causing problems with his speech and making it difficult for him to eat. This has led to significant weight loss in the recent months. He has a long-standing history of smoking and a habit of drinking 6 bottles of beer every weekend night. His vitals are all within normal range. Upon examination, there's a 2-centimeter mass noted on the tip of the tongue. After further tests, the mass is confirmed to be squamous cell carcinoma. For a thorough investigation of potential metastasis in this patient, it would be most suitable to examine which of the following lymph nodes first. A, lower cervical nodes. B, salivary nodes. C, nodes behind the pharynx. D, nodes beneath the chin. Or E, upper deep cervical nodes. What do you think is the best answer here? So this patient, what's really important for us to note is he has long-standing history of smoking. And what that can do is that can be a cellular stress that initially ends up giving you hyperplasia, but then can progress into neoplasia and subsequent carcinoma. Recall that it is going to be at the tip of the tongue. And oral cancers typically are going to drain to the submental lymph nodes. So what's high yield for us to note here is that lymph node drainage, you want to start with the cancer and then you want to track it backwards. So that brings us to the step beyond question. How does lymph node drainage differ between oral cavity tumors, which we said submental, and head and neck tumors? What do you think is the drainage to the head and neck? And that is going to be that the head and neck is going to be the deep cervical lymph nodes. So please note that when it comes to lymph node drainage, you should study it as if you have a cancer somewhere, and then you are going to track the lymphadenopathy backwards. In fact, on my YouTube channel, I actually have in my top NBME concepts playlist a whole video going through lymph node drainage. And I also include the lower extremity and inguinal lymph node drainage as well, because that can be a little bit of a challenging concept. So I hope you check this playlist out because it has many of the organ systems, and I just added this one as well as a few farm ones for you guys as well. All right. Are you guys learning something? Go ahead and type in yes into the chat box or thumbs up, letting me know you guys are active and engaged. Bunkil is Brandia, Marco. All right. If you're logged in and you haven't yet answered, we only have a few more questions left. So I would just encourage you all to go ahead and open up the chat box and answer with me so that we can finish this webinar together. All right. Which of the following is most likely the gateway through which the pathogen entered this patient's CNS? A 16-year-old adolescent is rushed to the emergency department by his parents due to an abrupt onset of disorientation and restlessness lasting for about 3 hours. He had returned from a summer camp 3 days prior, after which he developed fever, headache, stiffness in his neck, and bouts of vomiting. His parents confirm that he has no history of illicit drug use. Upon arrival, he appears combative and seems to be hallucinating. He is febrile, pulse is okay, respirators are okay, and blood pressure is relatively okay. A lumbar puncture is immediately conducted. Analysis of the CSF reveals the presence of both cysts and trophozoites. Which of the following is most likely the gateway through which the pathogen entered this patient's CNS? A, sinus cavity behind the eyes. B, nerve controlling facial muscles. C, sinus located in the forehead. D, sinus near the ear. E, nerve responsible for the sense of smell. Or F, nerve responsible for face sensation and chewing. All right. So let's go ahead and break down this question. When it comes to the tempo of this disease, it is acute onset. And whenever you see somebody is disoriented and restless acutely, you are going to be thinking of CNS dysfunction. And in particular, there are three kind of major things that you should be thinking of. An infection like meningitis, encephalitis. It could be a toxin mediated. For example, maybe you ingested something, or you're going to be thinking of trauma and specifically hemorrhage. Now, once they say that the patient has meningeal signs, infection goes up on your differential, and bouts of vomiting actually may indicate that the patient either is not feeling well, has systemic inflammation, or there is some increased intracranial pressure. Now, this patient actually has encephalitis. Remember, encephalitis usually has altered mental status in the test question. And with the prodrome of being at a summer camp and now the lumbar puncture showing cysts and trophozoites, you could be thinking of Naegleria Fowleri, and that ended up going up the cribriform plate, and that is the nerve responsible for the sense of smell. So remember that this is going to be kind of like one of those ascending infections, and they want you to know the anatomical tie-in of the cribriform plate. So speaking of anatomical tie-ins, let's go ahead and take this question a step beyond. The foramen rotundum, ovale, and spinosum has which of the following structures passing through them? Now recall that when you're getting a cranial anatomy question, these are going to be kind of diagonally situated. So remember that the rotundum has V2, the ovale is going to have V3, or the trigeminal division, mandibular division, of the trigeminal nerve. And then the foramen spinosum is going to have the middle meningeal artery, and damage to middle meningeal can cause you to have a epidural hematoma. And that's super high yield for you to know. All right. Which of the following substances has this patient most likely consumed? A 16-year-old adolescent is brought to the emergency department after his friends found him in a daze with a rigid, expressionless face at a gathering. His vital signs are as follows: pulse is 75, blood pressure 102/70. He is sitting in an upright posture, appearing to be in a catatonic state. Physical exam reveals stiffness. During the examination, he suddenly turned violent and attempts to attack the healthcare provider. Which of the following substances most likely was consumed? A potent CNS stimulant, an anxiolytic, a powerful CNS stimulant. Sorry, A and C may be the same answers when I wrote it. D, a semi-synthetic opioid, or E, a dissociative hallucinogen. So pick between D, and E. What do you think is the best answer here? Good. And think to yourself, what do you think is this hallucinogen? This is probably PCP because of the increased amounts of aggression. Something that you just want to note is whenever you are thinking about toxicology, just try to categorize the toxidrome into, number one, an upper or a downer. In this case, the patient is revved up, so it's an upper. So you know that if you then think about autonomics, it's high sympathetics type of thing, or a decrease in parasympathetics. In this case, the patient is not tachycardic, the patient is not going to be hypertensive, so cocaine is going to be less likely. And with the increased agitation and the fact that the patient may have superhuman strength, you are going to be thinking about PCP. So tying in PCP with some pharmacology. What anesthetic is used as a dissociative anesthetic and inhibits the NMDA receptor? What do you think is the answer to this step beyond question? Go ahead and type it into the chat. Excellent. If you're thinking ketamine, you're absolutely correct. We actually use this pretty commonly in the emergency department or where I work in the peds ICU. All right. Next question. If the significance level alpha is set to 0.01 instead of 0.05, what will most likely be the consequence of this decision? A clinical study is being performed to evaluate the efficacy of an experimental antihypertensive medication in comparison to a standard treatment. The study consists of 6,000 patients with primary hypertension who are primarily going to be divided into two groups. So the 6,000 are going to be 3,000 patients are given the novel medication, whereas the other 3,000 are given the placebo. So if the significance level is set to 0.01, drop from 0.05, what is going to be the consequence of the decision? Go ahead and read through the answer choices and put your answer into the chat box. All right, so the best answer is going to be A. Findings of significance will be presented with increased certainty. Recall that alpha is the probability of making a false positive. And remember that when the alpha was 0.05, the way you conceptualize it is you say there is a 5% chance that the observed difference between standard and control is due to just fluke or chance. But then when you say, wait a second, now there's only 1% chance that this happened out of randomness, you are going to have increased significance. And that's what the alpha level is. It is going to be the ability for us to be confident and say that this was not due to chance, or there's a minimal risk that it was due to chance alone. And we have detected a difference, especially when you have an alpha that is going to be 0.01. So let's go ahead and go into this biostats integration. What is it known as if you are stating that there is not an effect when in reality there is? What is it known as if you are stating that there is no effect, but in reality there is? Excellent. And that's going to be a beta or type 2 error. And essentially what you're saying is that there's no difference between control and the intervention group, but in true reality, there is. Now, beta errors can be overcome by increasing the sample size or power. So basically what you can do is you can get more patients enrolled in your studies, and that's what's going to help you increase your power. All right, very nice. What is the most likely cause of this patient's amenorrhea? A 16-year-old girl is brought to the clinic by her father due to an absence of menstrual periods for the past 5 months. The patient expresses indifference towards the absence of her menses. She experienced menarche at 11 years old, and her menses were regular every 28 days until they became erratic a year ago. She participates in her school's long-distance running team. She appears excessively thin and endorses headache. Her growth parameters are shown, and the BMI is 16. She is bradycardic, slightly hypotensive. What is the most likely cause of this patient's amenorrhea? Too much thyroid hormone, low gonadotropic, low sex hormone state, insufficient thyroid activity, disorder characterized by multiple cysts in the ovaries, or E, a tumor producing excessive prolactin. What do you think is the best answer here? All right. So this patient is going to have amenorrhea, and this amenorrhea is secondary amenorrhea because she had periods and now she doesn't. Now, because she's lost body weight, what ends up happening is that the whole body kind of shuts down and says, wait, you are not ready for childbearing. So what ends up happening is you have a reduction in the hypothalamic pituitary axis. So as you're going to have now low GnRH from the hypothalamus, and you're going to have low FSH and LH from the anterior pituitary, you are going to then downstream going to have less amount of estrogen. These patients, along with chronic overuse, are going to have weakened bones because they're not going to have as much estrogen, and their periods are going to shut down as well. This patient actually is going to be at risk for refeeding syndrome as well, especially because her BMI is very, very low, kind of like anorexia nervosa. And subsequently, when you give food, the excess amount of insulin is going to cause you to have electrolyte abnormalities like hypomagnesemia, hypophosphatemia, hypokalemia, and all of these can cause arrhythmias. And so always watch out for that part B question that they can give you on the USMLE. Low BMI, they just started feeds, and now all of these electrolyte derangements. All right. So apart from this maybe common scenario, what do you think is the most common cause of secondary amenorrhea? i.e., you had periods, but now you don't. Excellent. Not a trick question. The answer is going to be pregnancy. And remember that whenever a patient on step 1 or step 2 CK comes in with abdominal pain and their childbearing age, the first step in management is actually going to be get a beta HCG. All right, we are almost done. Thank you all for sticking with me. Let's go ahead and go into this biochemistry question. In this patient's liver, the level of which of the following metabolites is likely elevated? A 1-week-old breastfed girl is brought to the emergency department by her father because of inadequate weight gain and restlessness since birth, along with a 3-hour history of vomiting. Physical exam reveals jaundice and an enlarged liver. A urine test for reducing substances turns out to be positive, but a glucose oxidase test result is negative. In this patient's liver, the level of which of the following metabolites is likely elevated? Fructose 1,6-bisphosphate, galactose 1-phosphate, glucose 1-phosphate, glucose 6-phosphate. What do you think is the best answer here? So this patient is going to have emesis, jaundice, and hepatomegaly. And with the reducing substances turning out positive, most likely you are going to be thinking of the fact that the patient cannot break down lactose. And remember, if they can't break down lactose properly, they specifically are going to have, in this case, an inability to break down galactose. Because remember, lactose is going to be a combo of glucose and galactose. Now, the galactose breakdown impairment, that's going to be known as galactosemia. And in this patient, the galactosemia is going to cause them to have elevations in galactose 1-phosphate in the liver. So remember that galactose 1 uridyl transferase, that is going to be your rate-limiting enzyme for galactose breakdown. So in this case, the patient is going to have jaundice, hepatomegaly. They can even have cataracts in galactosemia. So what is the difference between aldolase B and aldose reductase? And this is kind of a parallel, not going towards more galactose, but another sugar, which is fructose. And remember that when it comes to aldose reductase, that's what gives you cataracts and say something like galactosemia. Whereas aldolase B, that is a rate-limiting enzyme in fructose metabolism. So what I like to think of is this mnemonic FAB-GUT. And so FAB-GUT tells me for fructose metabolism, rate-limiting enzyme is aldolase B. For galactose metabolism, rate-limiting enzyme is galactose 1 uridyl transferase. Remember that if they ask you what is going to be the mechanism behind the cataracts, it's going to be the increased amount of the osmotically active sugar, sorbitol. That brings me to a very important integration, and we're going to go through all of the USMLE questions related to cataracts. Now, what's high yield for us to note is that cataracts are going to be in your exam questions as decreased light reflex or hazy corneal reflex when light is shown in the eye. And the causes of cataracts could be acquired or congenital. So let's go ahead and go through some of the vignettes. Galactose disorders, that's what got us into this mess, galactosemia. Alport syndrome, remember these patients are going to have issues with the kidney as well, hematuria in particular. Patients with chronic corticosteroids that can lead to Cushingoid disease, NF2, rubella, remember deafness, cataracts, PDA as your triad, myotonic dystrophy, this is a CTG repeat disorder, and diabetes. So this is the way to kind of integrate everything together and will build a nice differential, especially if you're studying for step 2. All right, let's go ahead and go through this question. The antibiotic that would most be effective against this patient's condition would likely disrupt which of the following cellular processes or enzymes? A 27-year-old male is brought to the emergency room due to a week-long history of high fever, significant muscle pain, and painful swelling across his neck, armpits, and groin region. His symptoms commenced after a camping trip in Colorado. He seems very sick, is lethargic, and can hardly respond. He is febrile, tachycardic, tachypnic, and blood pressure is slightly low, 112/68. Physical examination reveals multiple scattered spots. An exam of the lower extremity reveals a red, solid, tender mass on the inner aspect of the leg just below the knee. The mass is draining blood and necrotic material. The antibiotic that would be most effective against this patient's condition would most likely disrupt which of the following processes? Cell wall, DNA helicase, glucuronyltransferase, proteasomal degradation, ribosomal assembly, or tetrahydrofolate activity. So this patient is going to have, again, infection or inflammation. That's the growing theme. And in the setting of these large buboes or swellings and Colorado, you're going to be thinking of Yersinia. Now, the patient is going to also have myositis, which is important for us to note related to Yersinia. They could also have hemorrhages under the skin or even petechiae. And typically, we are going to use aminoglycosides for Yersinia pestis infections. Remember, for a lot of the tick-borne illnesses, which is kind of parallel but separate from Yersinia, you're going to be using tetracyclines. Either way, your aminoglycosides as well as tetracyclines are going to affect translation, i.e. the assembly of ribosomes. Remember that synthesis of cell wall, that is going to be beta-lactams, particularly penicillins, as well as your cephalosporins, and tetrahydrofolate activity, that's going to be trimethoprim sulfamethoxazole. So along with teaching you USMLE content, I also want to teach you some life principles or financial principles. I like this mnemonic, which is buy at 30, sell at 50. It helps you remember the various antibiotics that hit the 30S and the 50S ribosomal subunit. So the 30S ribosomal subunit inhibitors are by AT at 30, aminoglycosides, gentamicin, neomycin, amikacin, tobramycin. The tetracyclines, things like doxycycline, also affect 30S. What are your 50S? Think of the mnemonic cell. Chloramphenicol, clindamycin, which is good for anaerobic bacteria, erythromycin, which is a macrolide, L for linazolid, and lincomycin as well. So buy at 30, sell at 50. I hope you enjoyed this mnemonic. All right. So this was a pharmacology question testing you on Yersinia pestis and aminoglycosides. And remember that the transmission vector of Yersinia pestis is going to be fleas. Let's go ahead and go into our next question. What additional findings is most likely in this patient? A 47-year-old man comes to the clinic accompanied by his wife, complaining of a 5-month history of progressive muscle weakness. In addition, he's experienced difficulty swallowing and has lost around 4 kilograms in weight during this period. Over the past month, he has increased tone in his legs, and that has become so severe that he needs a wheelchair for mobility. His medical history is unremarkable, and he does not take any medications. He formerly worked as an accountant and has no known exposures to toxins. He neither smokes nor drinks. Vital signs are stable. He's cognitively alert. Physical exam reveals fasciculations in the upper limbs and weakness in the lower limbs. What additional finding is most likely in this patient? A, muscular atrophy. B, reduced visual sharpness. C, a loss of body position. D, drooping of the eyelid. Or E, weakness improved on repeat stimulation of the muscle. What do you think is the best answer here? Excellent. So when we're thinking about this question, you want to integrate that this patient has hypertonia and is going to have fasciculations. Upper motor neuron plus lower motor neuron and a chronic tempo, you should be thinking about ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. And remember that that is going to be damage to the corticospinal tract as well as even the lower motor neuron. And so the best answer is going to be muscular atrophy. Answer choice D is more bulbar symptoms that would be potentially related to myasthenia gravis. And answer choice E is weakness improved on repeat stimulation of the muscle. That's going to be Lambert-Eaton syndrome. So remember that in this case, the best answer is muscular atrophy because of the lower motor neuron damage. We have 4 more questions left, and then we are done with this section. Considering the properties of killed vaccines compared to live vaccines, what is the most valid reason to develop a killed vaccine for the disease? A new and severe respiratory disease originating from a newly discovered virus has emerged. Considering the principles of killed vaccines compared to live vaccines, why do you want to develop a killed vaccine? A, it eliminates the risk of reversion to a virulent form. B, it provides faster protection against the disease. C, it is likely to require follow-up boosters for lifelong immunity. It is less likely to get the boosters. It is more likely to stimulate mucosal immunity, or it requires minimal safety checks. Remember that live vaccines, are going to have the risk of increasing the reactivation. So remember, when you have a killed vaccine, it eliminates the risk of reversion to a virulent form. Recall that we don't give live vaccines in patients who are going to be immunocompromised, as well as even in pregnancy. Let's go a step beyond. An infant presents with intussusception. What live vaccine would be contraindicated? So remember that a patient who has intussusception, you can't run the risk of more Peyer's patch hyperplasia. So the correct answer is going to be rotavirus. So rotavirus vaccine, if you have a history of intussusception, you may want to think twice. All right. This is like us being at block 7. You're not going to give up now. You're going to finish the race with me. Let's go ahead and just take a quick little deep breath and then lean into our final few questions. All right, guys, let's go ahead and stay active and engaged. Which of the following best explains the pathogenesis of this patient's disease? 33-year-old woman consults the physician with symptoms of mild nausea, frequent urination, constipation, and a recent weight loss of 10 pounds in the last 2 weeks. She also reports vaginal bleeding for the past 3 weeks. During the pelvic exam, there's a nodular cervix, irregular, friable, hard, uneven, immobile pelvic mass spanning across the pelvis. Biopsy of the cervix and the anterior vaginal wall reveal a well-differentiated keratinizing squamous cell carcinoma. Which of the following best explains the pathogenesis? A, suppression of p53. B, insertion of viral promoters next to cellular growth factor genes. C, specialized transduction. D, activation of cellular growth factor genes by TAX. Or E, c-MYC translocation. What do you think is the best answer here? Excellent. If you are thinking about this patient having cervical cancer and you are thinking about how this cancer proliferated, we've talked about this. It's a spaced repetition here, suppression of cellular p53. Let's go ahead and talk a little bit about HPV. As we transition the slide, real quick, what are the high-risk HPV strains? Go ahead and type the numbers into the chat box. High-risk HPV strains, you got it. 6 and 11 cause warts. 16, 18 is going to be related to cervical cancer. They're the higher risk strains. So the high-risk strains encode for E6 and E7. Now, these are going to make proteins. And what E6 does is it inactivates p53, whereas E7 is going to cause phosphorylation of retinoblastoma. That then inhibits retinoblastoma. So if the bodyguard is off of elongation factor 2, well, now no bodyguard, elongation factor 2 can do its job, i.e. it's going to keep causing cellular progression. So just as a review from our Burkitt's lymphoma video, we talked about how cancer is due to too much cell proliferation or decreased apoptosis. One of the key things that you need to note when it comes to neoplasia is understanding that malignant growths are fast, not slow. They have irregular borders. They have septations and calcification. At times, you can have painless neoplastic growths. You can have local invasion, i.e. nodal involvement, and they're going to be fixed to the architecture. And so what's important for us to note is that these are features of malignant tumors, and malignant tumors may have a poor grade, i.e. they are going to have high N/C ratio, disorganized growth, and a lack of cell polarity, what we call anaplasia. This patient is likely being treated with which of the following drugs? A 60-year-old woman presents to, or who has been living with type 1 diabetes for the past 45 years, presents to the clinic for her regular monitoring visit. She is currently undergoing hemodialysis due to end-stage renal disease and is in the queue for a renal transplant. As part of her treatment protocol, she is given frequent injections of a medication that triggers the release of reticulocytes from the bone marrow and stimulates a specific cytokine receptor, which functions via the JAK-STAT signaling pathway. This patient is likely being treated with which of the following drugs? RBC stimulating hormone, neutrophil growth factor, cytokine 2 or IL-2, growth factor associated with platelets, or colony stimulating factor affecting granulocytes and macrophages. Excellent. Very good. So what's important for us to note is that this patient is going to have end-stage renal disease. That means you have low peritubular capillary cells. As a result, you're not going to have as much erythropoietin. These patients can get anemia of chronic kidney disease. That's why we give exogenous EPO that stimulates reticulocytes. And remember, because it's a growth factor, it acts via the tyrosine kinase associated JAK-STAT pathway. Another thing for us to note is when it comes to your erythropoietin, it can have some side effects, which include hypertension, as well as increased blood viscosity. And that's super high yield. Let's say you have a high amount of erythropoietin from renal cell carcinoma or even polycythemia vera, you can get increased blood viscosity, which can lead to headaches, etc. So I just want to really highlight that when it comes to cell proliferators, they're going to work via the tyrosine kinase JAK-STAT pathway. So cell proliferators such as EPO, thrombopoietin, GCSF, which were all other answer choices. What's even more important for us to note is that growth hormone is going to act via tyrosine kinase associated JAK-STAT. Cytokines, IL-2, IL-6, these cytokines are going to act via tyrosine kinase associated JAK-STAT. And then others are things like prolactin, which is going to be released from the anterior pituitary. The reason why I think that the endocrine portion of my pass-fail course is super high yield is because what they can do is they can not only give you the background hormone, but they may assess what is the way that the hormone works, because step one is all about mechanisms, and that's super important for us to note. All right, this is going to be our last question. Is everybody ready to end this review? Go ahead and type in yes into the chat box. Thanks so much, Alejandra, for your amazing comments. All right, guys, let's go ahead and finish with our last question here. In comparison to the measurements taken before the start of the session, which of the following is most likely to be decreased? 35-year-old man who is a regular gym goer engages in a 20-minute high-intensity interval training session on a stationary bike. Maybe he's on a Peloton. His average heart rate for the final 2 minutes of the session climbs to 180. Measurements of various physiological parameters are taken during the last 60 seconds of his workout. In comparison to the start of the session, what's likely to have decreased? A, cardiac output, B, oxygen consumption, C, pulse pressure, D, stroke volume, E, systolic blood pressure, or F, total peripheral resistance. So this question is testing you on exercise. And remember that whenever you're exercising, all of answer choices A through E increase. And what you want is you want a low total peripheral resistance so that blood can flow to your muscles while you are going to be exercising. Recall that in exercise, along with the increase in heart rate and the increase in contractility and increase in cardiac output, you are also going to get increased pulmonary blood flow. Now, when it comes to increased pulmonary blood flow, that increased pulmonary blood flow is going to give you a higher V to Q ratio. And what essentially happens is that exercise gives you a high cardiac output because it's a sympathetic state. And from the right ventricle, you have more blood going to the pulmonary arteries. This increases the apical blood vessels, which is going to be found primarily in zone 1. And this reduces the dead space because now you are going to have alveoli that are going to be perfused by a capillary in the setting of just recruiting your lung as you are needing more oxygen and even ventilation. So last concept of the day, exercise, you have central and local responses. Central responses, they're all about high sympathetic, high heart rate, high contractility, high cardiac output. You're also going to have constriction of the gut vessels, and you are going to have increased venous return because you're going to constrict the veins and increase the amount of preload that is going to the heart. The local responses, that's exactly what we were talking about, right at the muscle level. If I'm going to be exercising, I want vasodilatory metabolites such as ADP or AMP that is going to dilate the skeletal muscle arterioles and reduce the total peripheral resistance so I get more blood flow to skeletal muscle. What's the autonomic receptor that mediates this? Go ahead and type that into the chat. Autonomic receptor that is going to mediate a reduction in total peripheral resistance. And the reduction in total peripheral resistance is actually going to be beta 2 mediated. Recall that alpha 1 is going to be vasoconstriction, whereas beta 2 is going to be a sympathetic receptor, but it's going to cause increase in cyclic AMP and vasodilation. And that's actually what contributes to the reduction in total peripheral resistance and increases the blood flow to the skeletal muscle in exercise. Well, I just want to say, speaking of exercise, thank you all from the bottom of my heart for attending today's session. I hope you found them helpful. Please note that I have the blocks 1 and 2 on my YouTube channel. And if you're interested, especially if you're in dedicated study and you want to just get a good review of everything in an active recall way, I'm going to be putting the link of my pass fail course, as well as a very important link. And that is like really after this session, if you can just spend 2 minutes, and it will only take 2 minutes of your time to just post a review about why you loved this session or why you love the way that I'm teaching or HyGuru methodologies, that would help me improve. That will help spread the message to other students. Remember that the pass fail course is the series of videos that I have that helps you prepare for the USMLE. It comes with custom UWorld question IDs so that you can assess your knowledge after every single very short video. If you are interested in enhancing the test-taking strategy, I've also created a class called the Test-Taking Strategies course. Now, this course is good for step 1 or step 2 CK. You learn how to approach various types of questions, and you learn how to augment your productivity. And I also provide you a study schedule on Notion that gives you a very nice way to categorize all of your NBME and UWorld notes. Please stay tuned to my channel. I already have a growing number of step 2 videos and step 2 curriculum that is coming up, working very hard along with my clinical work to kind of help optimize your education and just be very positive that I promise there's light at the end of the tunnel. So keep staying inspired. I really would be humbled for you to write a review or even post on Instagram. Follow me on Instagram as well. Share this with your friends. And I just want to say that you guys inspire me each and every day to kind of optimize USMLE content and preparation. So I just want to say thank you. And with that, we will end today's session. Before you leave, type in one thing you learned, and I will stick around for any questions that you may have. All right, guys, thank you. Kaylee, Stefan, Linton, Rockefeller, Marco, Senthil, Faith. Oh my gosh, so many people. I appreciate you guys staying until the very, very end. That means so much to me. Excellent.